Thank you, Dr. Phillips. So good morning, everybody. We're good with the slides. You can see those okay?
Yep, we're good.
Okay, great. So for those who I have yet to meet, my name is Jonathan Abraham. I'm one of the faculty at Corewell. I have a background in emergency medicine, and I have the pleasure to repeat a talk from the past couple of years on severe pain and management of pain crises in palliative and hospice patients. Those of you who have seen this lecture before know I like to sprinkle in some art history, and it all makes sense soon. But I appreciate you joining me and let me share a little bit this morning with you. So I like to start this lecture by talking about a real life patient, likely a palliative patient. Should palliative care have existed in her time? But the famed Mexican artist Frida Kahlo was, by all accounts, a a good candidate for palliative care. I include her story for a number of reasons, not only because one of her most famous paintings is entitled Henry Ford Hospital, where I did my fellowship in palliative medicine, but she lived a life of immense physical suffering, and by all accounts died in a pain crisis. Born in Mexico, she developed polio at age 6 and had some physical debility to that disability, but was able to maintain an active life until the age of 13 when she was involved in a near fatal streetcar accident in Mexico in which there was numerous fatalities. And she had health problems throughout her life stemming from this injury. Ultimately, as you can see it in this picture on the right, she actually learned to paint in bed when she was recuperating from this accident. Her mother bought her an easel and set up. This was a custom setup for Frida, given her supine position. And she learned to paint from this bed of recuperation. Towards the end of her life, the complications of her initial injury and her multiple surgeries added up. In the last 6 months of her life, her leg was amputated due to gangrene, and she likely died in a pain crisis from sepsis, presumed pneumonia, osteomyelitis, and she has documented in her journals the immense suffering that she experienced in her life. One of her final journal entries that has since been published was, quote, "They amputated my leg 6 months ago. They have given me centuries of torture, and at moments I almost lost my reason. I kept on waiting to kill myself. I hope the exit is joyful, and I hope to never come back." She was 47 years old when she passed away. And when you learn this about her, you see a theme of this sort of artistic renderings of physical pain in her work. So this painting is called The Broken Column. She painted this in 1944. And, she had terrible back problems. She wore a back brace. She had chronic pain. You can see, she is featured prominently in her work. It's like largely autobiographical. But this stone column, you could see her midline is exposed, as is much of the rest of her. And her spine is represented as this broken stone column. If you zoom in, I mean, this is not a high resolution photo, but you can see tears pouring down her cheeks. And then also these nails that are occupying virtually every exposed area of skin. Um, could this represent neuropathic pain? We don't really know, but you see these recurring themes again and again about or representations of physical suffering. I always have to give a shout out to a palliative professor emeritus Dan Hinshaw at University of Michigan, who has an entire art history, palliative art history lecture. So I stole some of my ideas from Dr. Hinshaw. So never forgot the lecture though. So um, going back to that title slide, you can see this is a deer in the woods, presumably attacked by hunters, but it has freed his face. There's again these sort of stabbing wounds all over this creature. The next time you're in a museum, you're appreciating her work. Take a look, see if there's any other clues to the experiences that she was having stemming from her ongoing health difficulties. So a little bit about me. That's my art history portion. I am from Boston, Massachusetts originally, adopted Michigander. I went to Tufts Medical School in Boston, then followed by emergency medicine residency in Ann Arbor, and hospice and palliative medicine fellowship at Henry Ford in Detroit before coming out here. I have no conflicts, and a little bit about our objectives today. So I'm hoping we will begin to understand what defines a pain crisis in palliative or hospice patient populations, and starting to build a strategy for utilizing parenteral opioids in a pain crisis. I mean, this is something that is a regular part of our profession. And so but for our fellows and learners, by the time you are out practicing on your own, this is going to be relatively rote, and you will develop a practice pattern and good habits throughout this year. We'll also identify a couple of advanced modalities, which beyond IV opioids, which can be used to address severe pain. Some of these have their own lecture entirely, like ketamine. We'll just sort of touch on those today. So what is a pain crisis? We talked about defining terms. This isn't my definition necessarily, but I would frame it as a severe or uncontrolled pain that causes extreme distress. It's already like you know it when you see it, right? It's subacute to acute on onset, and it requires immediate intervention. When palliative is available, other care teams will be looking to palliative or hospice to help fix it. So, developing a plan. Whenever we're walking into a crisis situation, I come from the emergency medicine world. You're walking into a patient's room, you have no idea what's going to go on, what's going on in there, how sick they are, but all plans start with a history and physical exam. Sometimes history is pretty limited based on how symptomatic they are, but trying to get at least a base understanding of what you are treating or what you're about asked to be treating as much as possible. Symptom crisis will limit history gathering, and be aware always that definitive treatment of the underlying cause of pain might not be opioids, right? If they have a surgical emergency, viscous, they have a bowel perforation from a colonic mass, you can escalate opioid doses, and maybe you should, but ultimately they need a surgical consultation or emergent imaging. Close coordination with your team. Again, coming from that emergency medicine background, I think of some of these situations almost like a resuscitation. You have a team. It's hard to resuscitate a patient. I don't just mean CPR and intubation, that sort of thing, but just having somebody to go and get meds the Pyxis, having good closed loop communication with staff, not just bedside nursing, social work, chaplain, child life, knowing your team and how they might be able to help support this patient and family in a moment of need. What are your routes to access? What medications make sense? Do you have an IV? Do you have a port that needs access? Are there other considerations? Um, uh, and then also considering, we always want to be on the lookout for cultural differences and goals of care. Patients who are saying, just knock me out. I don't want to be awake for any of this versus I want to be awake and have as little medication as possible. There's different cultures, religious beliefs that might place value in suffering. So check your own biases as always, and make no assumptions. But while you're sort of coming up with a plan here, so medication planning. This is a big focus of our talk today. So choosing your medications. Opioids, adjuncts. I tell our fellows to, well, start low, go slow, especially in the opioid naive patient. This is the first year where I'm giving this lecture without John Mulder's introduction, and thinking of the first year I gave this lecture, and he said, yeah, start low, go slow, but just go, which I liked. So opioid selection in the opioid naive patient. I always give a caveat here because there's a lot of different ways to do this, right? Thinking of Dr. Mulder's, just go, right? It's less important about the sort of fine details. I think as long as you are practicing safely and in a systematic fashion. And so this is one way to do it. This is the start low, go slow approach. So you have an IV. You have lots of opioids available. I mean, morphine, hydromorphone, fentanyl, but we'll start with morphine and hydromorphone. So a general safe starting dose, very conservative, morphine 1 milligram IV every 15 minutes as needed for severe pain. Every 15 minutes is a pretty rapid reassessment, and good luck giving them a dose of medicine and then going on to the next patient. You have to be around, and again, I don't like to just put this order in and then walk away and let our bedside nurse figure it out, because they may need dose adjustment very quickly. Hydromorphone 0.2 milligrams IV or sub-Q every 15 minutes as needed. And then those reassessments are really important. Every 15 minutes, some people, say, well, you could do every 10 minutes, every 12 minutes. Again, when you don't say they're elderly, they're frail, they have other comorbidities, they're opioid naive, you don't really know how this is going to go. 15 minutes is sort of on the more conservative end of things. And the reason that we're talking about these kind of intervals for reassessment is we assume or understand based on the literature that these are the peak effects of the medication when administered through the IV. When I was practicing emergency medicine, I'm currently 100% palliative, but I helped build a program in the ED at Butterworth. So I'm practicing ED, emergency department embedded palliative care. That's another story for another day. But I remember in my emergency medicine days, somebody, you have no history, they come in with terrible burns. We would do like 0.1 mg per kg for patients sort of in extremis. That's a pretty generous dose of morphine. So morphine 0.1 mg per kg. You could use that for kids too. So understand, in a Michigan average patient or a big burly guy, 1 milligram IV might not be very much, and you are likely going to have to redose, reassess, and you can repeat the 1 milligram or you can double it, and you can keep doing it. with this 15-minute interval, you're generally in the safe zone. You kind of know if they're going to have adverse effects, they're going to tell you within 15 minutes. For the opioid tolerant patient, requires a little bit more noodling. So you want to really calculate their previous 24-hour oral morphine equivalents if possible. Remember, if they're writhing around on the bed, moaning, screaming, you may not get a whole lot of data, and you kind of have to interpolate what data you can. Again, trying to practice safely, but addressing really severe symptoms. Um, just another caveat, the medical record might not be accurate. There are dose adjustments. Sometimes the patients are titrating their own medicine without informing their care teams. Sometimes I've seen more problems pop up when the patients are kind of over-reporting how many OMEs they're taking. So they're saying, "Oh, yes, I take every single available dose, and I've been adherent to the methadone, 30 milligrams 3 times a day." And then you give them, you do good math, you do good calculations and conversions, you account for incomplete cross tolerance, which we always do. And then they're obtunded, and you're very close to Narcaning this patient because something wasn't accurate in the history or something wasn't accurate in the charting. Um, I like to calculate the 24-hour OME total. And remember, if they've taken opioids in the past 24 hours and they're showing up in a pain crisis, well, maybe 100 of OMEs wasn't enough. So we're probably going to be at a higher number once we've reached analgesia. But I like to calculate those 24-hour OMEs and then take a 10% dose of that number. Again, this is after accounting for the incomplete cross tolerance, like dose reduction. And you rinse and repeat. Once you get your dose, you write medicine, you write route of access. I always like to check end organ function, so renal function if you're doing morphine, hepatic function if you are choosing hydromorphone, and then you're off to the races. So as always, a case is, a good way to sort of think about these. I mean, I think about a lot of these situations as sort of a math problem. So we'll dive right in. Mr. G, our hypothetical patient, a 59-year-old male with a history of metastatic prostate cancer with bone metastases, it presents in a pain crisis, and he's on the following home regimen. He's on MS Contin, so morphine extended release, 30 milligrams 3 times a day. Morphine immediate release, 30 milligrams, which is written every 4 hours as needed. And for this example, he's taking all 6 allowed doses in a 24-hour period. And so you sit down, you calculate that the OMEs total 270 milligrams in a 24-hour period. But you need to address the symptoms quickly, and so you're going to utilize IV morphine. So you do your conversion. And you remember that 10 milligrams of IV morphine is equivalent to 25 milligrams of oral morphine, and so you've calculated that this patient is taking roughly 100 milligrams of IV morphine, or the equivalent, in a 24-hour period. And so because we're going morphine to morphine, we don't need to necessarily account for the incomplete cross tolerance. And so that 10% rule, you calculated a PRN dose of 10.8 milligrams IV, which you round down to 10 milligrams IV because you don't want to piss off your nurses by getting cute with asking them to draw up 5.126 mLs of IV morphine. PCAs. I don't know how many of you, We use PCAs pumps at Corewell. We use them at where I did fellowship at Henry Ford. I love PCAs most of the time. When they work, they're the best thing ever. When they don't work, everyone has a headache. But for those of you who are less familiar, PCAs are, well, PCAs are stand for patient-controlled analgesia, and basically what it is a pain pump. It's a pump with a set IV dose of some medication that is controlled by the patient. They have a button. Here's the button, and they are able to dose themselves with a low dose of IV opioids. It can also provide a continuous infusion of medications. We're at the point of the lecture where the slides are advancing by themselves, so I may be jumping back and forth. I apologize if you uh, develop a migraine. So PCAs, what's the benefit of them? Well, I like them. They provide more immediate pain relief with fewer, and the literature shows that they, in general, provide fewer overall opioids than PRN, sort of Pyxis administered doses of opioids. Patients like the convenience. They're relatively safe because when they're controlled by the patient, if we're concerned about adverse effects like over sedation, if the patient's too sedate to press the button, they don't get the medicine. And there's also a lockout interval, meaning that they can't just hammer the button and get into an unsafe situation. They hit the button and then there's a cool down essentially, and it's preset intervals set by the ordering provider. I find that patients really like it, not only for the analgesic benefits, but some of the peace of mind. Like, there might be a real anticipatory component of their pain that is terrifying. They're like, I don't want to feel that way, and they're clutching that button with one hand. And so I find that patients, when they work, they're pretty happy with this. Um, uh, Provided they work, which, sometimes the button's unhooked from the pump. Um, so the other nice thing about PCAs is that it's a computer in the pump. And there's buttons on here, and I'll show you a little bit. You can interrogate the pump after it's been running, and you can see down to the fraction of a milligram how much medicine they've required, how many times they've pressed the button, how many times they've pressed the button and gotten locked out because they were hammering it like this is not working. It's recording all of that, and it can be very useful to us as we think about next steps or we think about dose adjustment and titration. So when is the right time to use it? So rapid dose finding, patients can be opioid naive or opioid tolerant. Find that anesthesia and surgery like to use this in postoperative pain. That might be stemming from some literature in anesthesia, which I cited before, in that patients in the postoperative period and specifically use fewer overall opioids when a PCA is utilized without sort of worsening pain reported. A patient where other routes, so oral or sublingual medications, may be contraindicated. But so just like there's, the right patient, there's also maybe the less ideal patient for this modality. So, do they have a cognitive or physical like disability that's a barrier to pressing the button? So you hand them the button and they don't know what they're looking at. They try to brush their teeth with it. That's probably not a great plan. Are they not expected to be on IV pain medicine for very long? You'll see my 7 dwarves here. I think the dwarves that we think of are not safe. He's, sleepy. Are they too sedate for this that you don't trust them to be managing their own medications, quote unquote, with limitations? Or dopey, which is probably not PC anymore, but somebody who is not really getting it. the safe way to use this device. I would also advise caution when using opioids in general, but the PCA in other certain patient populations. So the elderly, the frail, do they have end organ dysfunction, renal liver impairment? You don't really know if they're going to get toxic from built up metabolites. Just advise some caution before you jump to the PCA. You want maybe a little bit closer eye on those patients. Do they have other comorbidities like obstructive sleep apnea? Basically, all the soft contraindications to like hitting people hard with opioids or other sort of CNS depressing medications. Morbid obesity, are they, snoring away? These are relative contraindications. You got to do your best, but um, this is a busy slide. This is a flow sheet, two sort of pathways. We're not going to zoom in on this, but sort of a roadmap. So, like, how do we redose titrate? How do we dose adjust? When are we going down the opioid naive versus the opioid tolerant path? So, this is sort of a zoomed in version. And another sort of case example. Let me see here. So you say we have the same patient, and you've calculated that they would need roughly 60 milligrams of IV morphine in an outpatient setting. And so they are opioid tolerant. And so you're thinking a PCA might be helpful here. And you want to, excuse me, I'm not sure why it decides to do this, but um, that you want to not only have a demand dose with a button, you want to include a continuous infusion, which is also a capability of these pumps. So you roll the entirety of their OMEs into a continuous infusion. And then you have a demand dose, which matches the infusion. So you calculate 60 milligrams IV in a 24-hour period. You calculate that as 2.5 milligrams per hour of that continuous rate. And then the demand dose is the same, 2.5 milligrams. Note that that's significantly less than what I shared before, that 10% number. And that's because, we don't want to overshoot. We want that precision that the PCA allows for. And we decide on a lockout interval of 10 minutes, right? We talked about 15 minutes. It could be 10 minutes, could be 12. I like to utilize something that is that 60 minutes is divisible by, so you can calculate like 6 doses in an hour versus 7.25 doses in an hour, right? Like make your math. We do a lot of math. Make it easy for yourself. So I talked about reports. You go see this patient the next morning. It was a great night, allegedly, and you want to interrogate the pump, look at the data that it's collected for you overnight. I mean, the best source of data is the patient, and they'll say, hey, this sucks, doc. Like you got more work to do. Or they're saying, hey, this was all right. But the pump will tell you more. So you can see in this particular patient, they recorded 52 doses given and 52 doses attempted, meaning that they did not lock out. If you see a discordance between these two numbers, say it was 100 doses attempted and 52 administered, that they locked out 48 times, and that is a clue that you might need to do some dose adjustment or talk to the patient. Was this a bad hour in the night where they were taken down for an MRI and they hammered the button incessantly because moving from here to there, from the bed to the scanner was misery for them? Or was this sort of a consistent failure or underdosing or undertreating their severe pain? Again, I think if there's PCAs available at your institution and you're not currently utilizing them, there's a lot of research and literature out there. There are, colleagues at our institution and others, I'm sure, who have a lot of experience with these and are happy to share their experiences with you if you want to build up, policy on utilizing PCAs, because I think again they can be very, very helpful when we have patients with severe pain in the hospital. We also have PCAs in the home setting on hospice. but we're kind of focusing on the inpatient experience today. Uh, so moving right along, ketamine, we're getting into our adjuncts here. So there's an entire lecture on ketamine later on this year. It's a great medication, very interesting medication. It's on the World Health Organization list of critical medicines. Um, Coming from the emergency medicine world, it's like the Frank's Red Hot of emergency medicine. It's like we put it on everything. It's been used for decades as a general anesthetic, including battlefield anesthesia during the Vietnam War. It has an amazing shelf life. It can be reconstituted, in a resource limited environment. But in the early 1990s, it was first reported used in a sub-anesthetic dose for cancer pain and showing efficacy in treating opioid-resistant pain, which was really interesting. It's a derivative of PCP, phencyclidine. It's a racemic mixture for those who miss their organic chemistry. It's highly lipophilic, water soluble, easily crosses the blood-brain barrier, and it's a potent NMDA antagonist. So, uh, and you know that is an important consideration in the setting of decreased opioid responsiveness. So it's a different pain receptor to target. It does interact slightly with the opioid mu receptor, but the clinical benefit or significance is not really known. But it can be given IM, sub-Q, IV, orally, intranasally. But just be aware that the bioavailability might vary drastically between these two routes of administration. So the advantages here, I said, multiple routes of administration can treat severe pain when opioids are less effective. I like to think of the hypothetical, but maybe real hypothetical patient who has been unintentionally overdosed or intentionally overdosed on opioids, and they have terrible cancer pain, but they need Narcan, and you are setting them up for a bad time in order to save their life by giving them Narcan. We try to be thoughtful about Narcan administration. Again, this is a little bit of a slight tangent. I won't divert too much into the Narcan discussion, but a low dose of Narcan just to titrate to respiratory drive is pretty good. But we know in the middle of the night that may not happen, and somebody's going to get slammed with Narcan, and now they're in a true pain crisis and opioid withdrawal. And ketamine might be something that can address a lot of misery for these patients. It's relatively inexpensive, widely available. I mean, mostly inpatient. There is a lower risk of hemodynamic compromise, respiratory depression, although, again, my caveat to that is that take that with a grain of salt. Especially if somebody's received a decent amount of opioids. I have personally had patients who go apneic when giving ketamine. I think it was just a sort of a receptor saturation issue. So just whenever you're introducing a new medication chemical into this patient's complicated blood chemistry, just keep an eye on things. Drawbacks of ketamine, there can be side effects like many medications. I think the psychomimetic side effects are the most pronounced. So patients can experience delusions. I mean, we use sub-anesthetic doses, but even those can trigger delusions, delirium, hallucinations. Nausea is something else that also is seen in some patients. It may cause increased intracranial pressure, intraocular pressure. There's mixed evidence on this. It's something that I sort of acknowledge in the back of my mind, but it doesn't really drive my clinical decision making. Although if somebody has a evolving subarachnoid hemorrhage and you're reaching for the ketamine because they have terrible cancer pain, maybe talk to the neurosurgeons before you just start uh, pulling ketamine drips. So how do we dose it in acute pain settings? In 2018, there was a statement or guideline, consensus guidelines from the pain anesthesia world. They talk about bolus doses and infusion rates. This is typically higher than what we will typically reach for in our space, but they suggested that bolus doses shouldn't exceed 0.35 mg per kg. Infusion rates shouldn't exceed 1 mg per kg per hour. Again, like our patients in our hospital, we might be starting them on 5 mg an hour, right? I mean, a Michigan average 80-kilogram guy, we're falling well short of that infusion rate ceiling. And then chronic pain therapy, this is closer to what we're doing is, 0.1, 0.2, 0.5 mg per kg per hour is recommended. And when we're sort of lower in that range, I'm a 0.2 guy for whatever reason. I don't know, that's a number that sticks out in my mind. Maybe it's from a paper I read once. That I have personally, anecdotally, not seen a tremendous amount of that sort of like psychomimetic side effects that I mentioned. So this is all like off-label FDA use. It is FDA approved for treating refractory depression. So you'll see some like, clinics offering ketamine infusions, maybe monthly for treating refractory depression. That might be covered by insurance. And so that's something also to consider in your back pocket. If, in palliative medicine, we are seeing people with refractory depression. And you might be the closest they have to a psychiatrist in your community because of that could offer a ketamine infusion that might help them. So it's just something to keep in mind. Um, uh, and I want to touch briefly on medicine that I've spent a lot of time looking at and pondering and talking about with various colleagues in pharmacy, in palliative medicine, patients, hospital supervisors, because uh, it always seems to raise questions. But dexmedetomidine is an evolving or emerging adjunct in uh, pain crises in the palliative space. It is newer to the scene. It's an older med, well, introduced in 1999. It's sad for me to say that that's older now. It seems like not too long ago. But Precedex, dexmedetomidine, it was sort of unavailable for the outside of anesthesia world because of prohibitive pricing. It was very expensive, and then went generic a couple of years ago. And it first garnered attention as a potent sedative, but it also had analgesic properties without causing respiratory depression. It's in the same family of drugs as clonidine, but causes less vasodilatation. So like clonidine, I don't know how commonly it's prescribed for hypertension anymore, but it causes more sedation than clonidine with less vasodilatation. It can cause bradycardia. And it's a very unique medicine and similar to ketamine in that way. And that has a lot of interesting, I guess, variable utility, right? Like we're giving ketamine to provide general anesthesia for surgery, like leg amputations in the battlefield, or we're giving it low dose for depression. Like that's a wild chemical. Whatever it's doing is pretty interesting. Precedex is similar. It has analgesic properties. It has anxiolytic properties. So, like, you might see it as a sole agent for somebody who's intubated and sedated. It's like doing it all, versus like a propofol infusion and a fentanyl infusion, because the propofol doesn't really treat the pain or the air hunger, and the sedative properties as well. And so, it's used mostly for intubated, uh, mechanically ventilated patients, severe alcohol withdrawal. You might see it facilitating BiPAP or non-invasive ventilation on a patient. And so it's primarily used in those cases. However, we have used it several times in patients who are nearing end of life, for whom the opioid ketamine approach is not working. Maybe we are reaching one of my favorite words, tachyphylaxis, which is the scariest word for like not that scary a thing. We're reaching the therapeutic benefit of the medication. Okay. And so, maybe you're on some crazy high doses of a fentanyl. If you're on 1,000 micrograms an hour of fentanyl with 500 microgram bolus, you cannot keep enough fentanyl going for this patient. And they're saying, no, this is still not working for me. We had a patient who was in that situation. Maybe I think there was also like a opioid use disorder history, maybe, and high methadone use. And we were kind of like running into a lot of barriers to getting this patient comfortable. And ketamine was off the table because this is a patient who had terrible, terrible, terrifying hallucinations, had a PTSD, sort of sexual assault history, and the ketamine like brought all of that back. And so that was completely off the table. And we started asking ourselves, well, what about Precedex? Um, and we, working with our pharmacy colleagues, we're off policy. This is sort of a new area of exploration. We were able to get it approved. We started this medication, and within, I think, 12 hours, we had cut the fentanyl infusion in half, which was just incredible, and didn't have any of those sort of, the sort of psychiatric or psychotropic side effects that we were on the lookout for. So one of our recently graduated fellow, Dr. Inger, wrote about one of these patients, and we've had former fellows write up these patients and get accepted to HPM to talk about, this emerging medication, and that might really help our patients. And so you'll hear about this. You might start using it in your practice. I think that's a pretty exciting option for us when things aren't really working. That's a terrible feeling as a provider. And so to have something in your back pocket that might actually help these patients and families, I mean, that's a good thing. You just got to convince your hospital supervisors that you're doing the right thing, that you're doing something that's somewhat evidence-based. So I'm reaching the end of my chat with y'all. In summary, pain crises, they're true crises, okay? Like, if the people around you aren't recognizing it, the patient certainly is, and they need to be identified and intervened upon quickly. Remember, the best treatment may not be a medication. I think palliative can be a victim of its own success. And when patient has worsening pain from known cancer, and are already established or followed by palliative care, sometimes there's a bias from the other teams, which is reasonable. It's sort of a cognitive offloading of pain is a palliative issue, which is not always the case, or not always what's best for the patient. So just, get a complete history, do an exam, understand what you're treating, and remember that opioids might not be the best, treatment for their pain. but they certainly can help while we're getting that definitive treatment. Remember, start low and go slow in the opioid naive, the medically complicated, the frail, the elderly. For opioid tolerant and opioid naive patients, really double check your math. I cannot tell you how many times I feel like I'm a big bad palliative doctor, and I'm like, I got this, and I calculate a number and I put it in, and I'm like doing a post calculation, post order recalculation. I'm like, oh my gosh, I was so off. Or I have a colleague be like, John, what the heck are you doing, dude? Like this is you were off somewhere. And that almost universally happens when I'm not actually busting out a calculator. And I'm pretty good at math, but don't get overconfident, don't get cocky, double check your calculations. You won't regret it. And it takes 2 seconds. And remember, in certain circumstances, patient-controlled analgesia, so PCAs, ketamine, or other medications might be helpful. They might save a lot of patient suffering and staff suffering too. And remember Frida, she by all accounts died, in a pain crisis. Unfortunately, in the time where palliative medicine didn't exist, morphine did, but I'm sure that she had symptoms that weren't adequately controlled, as she documented herself in her journal. And remember, always, you may not get a second chance to get it right. So this is vitally important work that we do, and should be approached with that gravitas. That's all I got. Thank you so much. I really appreciate giving this talk every year and spending some time with you. And I will stop sharing my screen and open up the chat, the text, the voice, what have you, for any discussions, thoughts.
I guess I have a question as a fellow ER physician, on the ketamine, I guess, overall assessment for palliation. I don't know, I'm sure you've experienced, or maybe you haven't. I've had where it's been given in excessive doses in error, obviously more in pediatric sedations. And the good news is, while it was a sentinel event, because it was given at about 100 times the dose that should have been given, the side effect profile of ketamine, you would think that would cause like an insane, duration of action, or, excessive cardiovascular side effects. They were essentially like equivalent. I think the extension of the sedation for the child was, I don't know, 10% more. And so from like a safety standpoint, I see ketamine as, when we obviously more towards children, which I think is interesting that it's considered palliative in adults because of that MDA, the bad trip idea. Also why it's abused, Special K pulled from like veterinary clinics. There used to be like robberies. You don't hear that about other drugs. And so we always shied away from it. I trained at Butterworth, like we shied away from ketamine in adults for that, specifically for the reason of the psychotropic sort of, emergent reaction. It was sort of terrible for the patient. Whereas you didn't get it with children with the thought that they don't have the experiential trauma to potentially contribute to a bad trip. They sort of are naive. But I just thought it was interesting that we had this case where like the dose was way out of proportion, and you would be like panicking and there's no reversal agent, and they did fine. You know what I mean? And so I always lean towards very high doses of ketamine. As you said, go low and slow. For ketamine, it was always like go high, because especially in peds, if we didn't have IV access, you had an IM dose that you might have one shot at, and you didn't want them waking up early, and you didn't want them not down far enough. So it was like 2 to 4 mgs per kg IM, and I'd always go 4. My attendings would always say, just do the 4, right? Because 2 might not be enough. And then for IV, it was the same thing. And then after the experience of the overdose, or whatever you want to call that, you really realize that like ketamine is better on the higher end as far, I mean, again, that's sedation versus pain control, which is different animals. But I just think of all those components, but then I think about the tachycardia and the cardiovascular, activation of ketamine, which is why we like it sometimes. So it feels safer. But if you're trying to help somebody with pain and maybe end of life, to me, that would be counterintuitive because you're making them tachycardic, dilating their airways, which is really great for sedation, for safety. And that's why, like, to me, it's sort of, I don't know. I don't know what your experience is. Obviously, I'm brand new to this. From this side of it is the success of ketamine in with all the like good and bad for palliation.
That's a very good comment. I
That's
think
very long. Like,
whenever I'm thinking of utilizing a medication, I work in the ER now, but I've spent most of my palliative career in an inpatient setting. And I think, you're always going to be bound. In my experience, again, this is pretty anecdotal, but you're bound to unit policies and protocols, and your dose limit is often dictated by those policies. The charge nurse will say, "Hey, that's way too much. We cannot do that. That qualifies as sedation. We need anesthesia to come to the bedside to do that." In the ED, in the What's that?
I'm sorry, I was making a joke.
Oh, no, no,
We
no,
have an
no.
anesthesiologist right here. I mean, yeah.
Oh, yeah. So I think those. So we have some. There's art in medicine, right? Like we try to practice evidence-based medicine, but there's variation and variability in that, and but I feel like there is the rate limiting step sometimes is what the bedside staff is comfortable. And I joke with this isn't just ketamine. I joke with my fellows in that if a bedside nurse balks when you order the 12 milligram push of IV morphine, you're like, and then you're like, okay, well, what about 4 milligrams of Dilaudid? They're like, oh yeah, the 4 milligrams is fine. 12 is too high. There is a bias towards all these medications, and so just being aware of that and the policies and protocols, which may vary greatly from institution. In the ED, it's sort of like the Wild West. We do whatever the heck we want most of
well, I feel like it's more like that in hospice.
the time. True.
The outcomes are different. But
Yeah.
I guess my question is at the palliative doses that you're
Mhm.
using it for more for pain control in adults, are you not experiencing the emergence or whatever you want to, the
Yeah.
psychotropic
Yeah, the
part of it?
sub-dissociative dosing is that
Yes.
0.2 mg per kg to 0.5 mg per kg per hour. Okay, these are not bolus doses. This is the infusion, and sometimes
Yeah.
people will be on a ketamine infusion for days. And so those doses are based on, they're based on the literature citing analgesic benefit with minimal side effects of that sort of the psychotropic or the altered sensorium, that sort of thing.
Yeah. Do you still get the tachycardia and those,
I mean, not clinically significant. No, I mean,
Okay.
we're not like cranking them up. They don't. I haven't seen like the sialorrhea, like you give a
Yeah.
bolus, they're drooling. I mean, we're not seeing much different, but they're more comfortable. That's a nice thing.
I actually have a relevant case from pediatrics over on the DeVos Children's side. We had a patient that just died earlier this week from the complications of acute graft versus host disease for a bone marrow transplant. And she's a 2-year-old, and we're having a struggle with trying to get her comfortable on multiple infusions and just pain and needing sedation as well, palliative sedation. And we ended up using, in combination with other drugs, we used ketamine. I'm more comfortable doing like the 0.1 mg per kg dosing for pain control. That's usually where I generally sit. But we ended up doing 0.5 mg per kg for her, and it still wasn't sedating her entirely, in addition to Dilaudid infusions and other things, which shocked me. I was like, wow, in combination, all these things, I definitely thought we were going to have, I thought you were going to be knocked out by this. And she would get Q6 hour dosing overnight. I think it was Q4 hour dosing overnight. I apologize. But ultimately, she was able to be very, very comfortable with that regimen. And we didn't really experience a whole lot of the secondary side effects. Honestly, her heart rate was still pretty reasonable. And she had pain and other things. So it's complicated to say, if it was just the ketamine, but her heart rate was not very high. And she was incredibly comfortable, and that's essentially that carried you through to the end of life.
And Rachel, you raised a good point there too. We have doses that we've got the recommended doses, but yes, go low, go slow. But as John said, and thanks for bringing that up again, John, just go. So if you do need to go higher than the recommended doses, there's definitely room to do that for these pain crises. So prime example of being able to get that pain under control, symptoms or side effects are still at a minimum. So thank you for sharing.
And would it have been like frowned upon if in a 2-year-old like that, who's like maxing out, pain control in a terrible way to die kind of situation, that if you had bumped her ketamine to more of maybe the lower end of you said 0.5, like God forbid you got to 1 or 2, per kilo IV, which we've established that you basically can't overdose ketamine, and she was like sedated, more than just pain controlled. Would that have been a bad thing, or that's not allowed in the hospital setting without like direct anesthesia?
So it's interesting. They weren't even, prior to a couple of months ago, we weren't even allowed to give any ketamine on the floor. It had to be in the ICU, which we've balked at for a long time. And even intermittent dosing, I can see an infusion. They want to have that in the ICU, but really, like, we were like, we just need to use it as an adjuvant here. Sorry for my child in the background. But they ultimately did allow us to do intermittent ketamine dosing, and that's been a big win for us recently on the oncology floor. I'm sure if we were getting into those doses that we would need to have someone else there. But that being said, we were essentially doing inpatient hospice care, and the team kind of turned it over to us. So I don't know. We haven't challenged that yet in the hospital. So to be determined. But
and just from like a pure suffering, that's an exceptional case. But in a small child, like where you're just like trying to get them actually comfortable, you would hope that maybe they would give some flexibility. But
yeah, I mean, we were doing significant doses of all of her medications, so not something that we would be doing in any other scenario. So we did have some leeway there. Yeah.
I'm just going to throw this out there for consideration. It's something that I'm looking at in very early stages, but interventional pain modalities, if you have access to an acute care pain service, or you have an anesthesiologist that's willing to work with you, start to look at things like erector spinae blocks, epidurals, continuous pumps, intrathecal pumps, or peripheral nerve blocks with a continuous infusion. I'm interested in expanding that world in palliative care. So hopefully over the course of the year.
You'll enjoy Dr. Rowe's lecture later this year, where she talks all about the various sort of interventional approaches to.
I've looked at it, and it's an excellent introduction to that topic.
Well, thank you so much again, everybody. I appreciate this talk, giving this talk every year, and I'm honored to be invited back. So enjoy the rest of your day. I got to hop off and get to work, but thanks again.
Well, thank you, John, for joining us.
Absolutely.
And as part of that transition too, go ahead and take a look at that lecture from last year too on Precedex. Dr. Inger did a good job of introducing the topic and letting us know how she's been using it. So that was just about last May, early June or so. So again, take a look at the YouTube channel.
I actually told Ryan about it yesterday and he found it. So he can, I mean, it is accessible, and he was interested too. Yeah, it's used inpatient, but
and Amy's been doing some of that Precedex at Trillium as well. So
nothing like getting started on day 2 using precedent.